Hi, everyone. I'm Jacob Stevens. I'm a clinical nephrologist here at Columbia University and the director of acute care nephrology. Thanks for having me today. I'll be discussing the perioperative challenges of our dialysis-dependent patients. I have no relevant financial disclosures. So we'll focus specifically on cardiovascular disease resulting in cardiac surgery in our ESRD patients. And we have to begin by reviewing cardiopulmonary bypass itself. Then we'll explore some of the unique challenges that bypass creates for ESRD patients. We'll review different strategies that are available, including zero balance ultrafiltration. And we'll finish by me sharing the experience we've had at Columbia using this protocol. So any surgical procedure which requires the heart to not be contracting, which is the majority of cases, requires heart-lung machine to provide mechanical support, oxygenation, and ventilation while the heart and lungs are bypassed. Patients are subjected to such procedures requiring this bypass since they often provide the long-term functional improvements that are desired, but this comes at the cost of significant short-term morbidity and mortality. And estimates from the Adult Cardiac Surgery Database from the Society of Thoracic Surgeons, or the STS, show an overall mortality of 2 to 6%, and a combined mortality and morbidity of 17 to 28% for all comers. And this risk is even greater in patients with dialysis-dependent end-stage renal disease. Given the high co-prevalence of ESRD and coronary artery disease, many procedures requiring bypass support are performed on our patients each year, and cardiovascular disease remains the most common cause of death in our patients. The first case report of a cardiac surgical procedure with bypass performed in a patient who was on preoperative dialysis dates as far back as 1968. Since then, longitudinal outcomes for this patient population have highlighted the significant risks associated with the preoperative dialysis dependency, and dialysis status is now one of the key risk variables used in the STS score for predicting morbidity and mortality. Based on some simulations, ESRD patients undergoing coronary artery bypass grafting have a 2.4-fold increased risk of perioperative death and a 1.9-fold increased risk of the composite of short-term death or morbidity, defined as stroke, prolonged ventilation, deep sternal wound infection, and reoperation, compared to matched controls with normal renal function. Increased duration of mechanical ventilation, increased intensive care unit length of stay, increased infection and bleeding risk have all likely contributed to this increased morbidity and mortality that's observed for our patients. But what exactly is cardiopulmonary bypass? Well, it does provide complete mechanical circulatory support, oxygenation of the blood, and ventilation of the blood. And deoxygenated blood is siphoned away from the right heart and enters a central venous reservoir in the extracorporeal circuit. From here, it then enters an oxygenator and gas exchanger, much like ECMO circuits for anyone who's familiar with ECMO, where it comes into contact with sweet gas, which is high in oxygen and allows for the removal of carbon dioxide. That oxygenated blood is then returned to the aorta, distal to the cross clamp, and prevents blood from entering the left ventricle in a retrograde fashion. With the blood now bypassing the heart completely and the lungs, the surgeon can intervene on the heart, but only after it stops beating. And so this requires a potassium-rich cardioplegia solution to be used, which transition us nicely into the unique challenges that bypass creates for patients who have ESRD. And so in order to achieve that cardiac standstill, some oxygenated blood actually leaves the oxygenator and gas exchanger on a side port and is mixed with the cardioplegia solution, which has a high potassium concentration of approximately 26 milliequivalents per liter. This bloodline is then infused into the coronary artery ostia in an anterograde fashion, and sometimes and often in a retrograde fashion into the coronary venous sinus. This allows the surgeon to perform the operation without any cardiac motion, because typically the cardiac myocytes have a resting potential that's approximately negative 85 millivolts due to some of the electrical potentials of sodium, potassium, and chloride based on their extracellular to intracellular gradients. A little flashback to medical school. And this allows for the cells to have a resting potential that's well below the threshold potential. However, with increasing extracellular potassium concentrations, so this is idealized at 4 milliequivalents per liter of extracellular potassium concentration, this is depicting what happens at 10, and this is depicting what happens at 20. You have resulting a new resting potential is established, and this depolarized resting potential is depicted here in those red arrows as low as -46. So that depolarization causes a contraction, followed by intracellular calcium being sequestered in the sarcoplasmic reticulum via the ATP-dependent calcium pumps, and the cell relaxes into diastole. However, that high potassium concentration of the cardioplegia extracellular solution kind of clamps the cell at a less negative resting potential than the threshold potential and inactivates sodium channels. And this prevents any repolarization from happening. And so this results in diastolic asystole. This effect is seen electrophysiologically on the ECG, which shows the progressive loss of P waves, increasing T wave amplitude, widening of the QRS, and eventually asystole as the potassium concentration increases. To liberate a patient from cardiopulmonary bypass and have them leave the OR and go into the CT-ICU, a normal plasma potassium concentration must be reestablished in order to allow the successful native cardiac conduction and return of spontaneous circulation. Inadequate or delayed control of hyperkalemia can lead to persistent cardiac asystole and an inability to liberate from cardiopulmonary bypass support. Anuric patients lack that normal renal homeostatic function, which typically allows for the protection from these unique intraoperative challenges, including hyperkalemia. And without that native clearance, we really need intraoperative kidney replacement therapies to be employed for such cases so that they can be liberated from the bypass machine, they can leave the OR and be brought to the ICU for post-op recovery. While we as treating clinicians must address all the intraoperative physiologic derangements, including volume overload and acidemia, hyperkalemia does take the front and center stage, and it's the most consequential intraoperative complication of impaired renal clearance. And it'll be the focus on the remainder of this talk. So in addition to the cardioplegia solution, we'll fill in some other sources of both exogenous and endogenous potassium release into this table. Let's start with the other significant source of exogenous potassium, which is the transfusions of stored red blood cells. So the potassium concentration of the supernatant of stored blood cells increases predictably and somewhat linearly over time, is approximately equal to the length of the number of days it's been in storage. So this is one case report from 2010 showing that the initial potassium concentration in a pack of red blood cells was 2.4, and that increased to 63 after 42 days of storage. So that's after 6 weeks, it went up to 63. How consequential is this? Well, it's particularly a problem when more than one unit of blood is being transfused, or when the blood needs to be transfused very rapidly, or when patients don't have intact renal function to deal with the potassium load, which are all features of our ESRD patients who are undergoing cardiac surgery, where sometimes 10, 11 units of red blood cells are infused very rapidly without any ability to clear the potassium natively with their kidneys. And so this is just an idealized single compartment schematic, when in real life there are 3 compartments of what would happen instantaneously to the intravascular potassium after 1 unit of blood with a high potassium is infused. So again, this is just to demonstrate in setting up a rapid infusion of a pack of red blood cells with no other shifting or movement across compartments, what would happen. The high potassium in the supernatant, 45 in this example, is in only 110 milliliters of liquid. The rest is the cellular volume of that pack of red blood cells. And so that equals about 5 milliequivalents of potassium that we're adding to the system. Of the nearly 5 liters of blood volume, the plasma volume is only about 2.3 liters. And the total potassium content of that intravascular plasma working off of potassium of 4 is approximately 9 milliequivalents. So we had 9 milliequivalents to start, we're adding 5. Now there are 14 milliequivalents in the intravascular space. The intravascular space has now been expanded to 2.4 liters. And so when you take 14 milliequivalents and divide by 2.4 liters, you get a new potassium concentration of around 5.9. So we went from 4 to 5.9, if we rapidly transfused 1 unit of red blood cells. Obviously, there's a lot of shifting that occurs, but this is to demonstrate that the concentration in the intravascular space can increase quite significantly and very quickly. One strategy to attenuate that potassium load that's associated with the intraoperative infusions is to use an autologous cell salvage device, which is normally used to wash autologous blood that's taken from the surgical field, the patient's own surgical field, and is mixed with crystalloid or rinsed or washed with crystalloid. And then that combination of the patient's blood and the new crystalloid is centrifuged in this device. And then that hemoconcentrated blood is then transfused back into the patient. We can commandeer that technique, and we do, for transfusion of non-autologous blood during the cases. So in patients with ESRD who are requiring high volume of red blood cell transfusions, we often hook the blood transfusion into this device, wash it with crystalloid, hemoconcentrate it, and then infuse it into the patient that way. This case report here is showing you what happened and just how effective that washing with these cell salvage devices can be. It details that this particular case, there were 4 units of blood given during the case for an average potassium concentration of around 40 milliequivalents per liter. And that was before they were washed. After they did this procedure, the mean concentration fell and it was effectively lowered to 2.3. So a very effective method if used, and one way to prevent the potassium from ever entering the system to begin with. In addition to those exogenous sources, there's also potassium that enters the blood from transcellular shifting. For example, during the rewarming phase of iatrogenic hypothermia, which is often necessary in these cases, acidemia, or from tissue release, either in vivo or in-circuit hemolysis, and from rhabdomyolysis in particularly long cases. And then finally, the entire premise of this topic, which is inadequate potassium excretion that's seen in ESRD and in acute kidney injury. Typically, in patients with normal renal function, this high potassium load is eventually circulated systemically and then it's excreted by the kidneys. But this study from the 1980s shows the increased caloresis that follows cardiopulmonary bypass and cardioplegia. The control patients are shown in these open white bars. And the 3 different time periods that we're looking at is the pre-operative, the intra-operative, and the post-operative periods. And this is just demonstrating what the urinary potassium excretion is on the top and the plasma potassium concentration on the bottom. The hashed bars are the study group. So these are patients who received cardioplegia solution that contained potassium, whereas the control patients did not have potassium in their cardioplegic solutions. That top panel shows or demonstrates that there is significantly greater potassium urinary excretion in the study group, which had potassium containing cardioplegia, and that extended into the post-operative period. Not surprisingly, there were no differences in the pre-operative period. And what's interesting is that despite having increased caloresis, there's a consequent rise in the serum potassium that persists, well, that initiates intraoperatively and then persists post-operatively. So the takeaway here is that even in patients with normal renal function, which is the study was, and an intact ability to excrete potassium, it still takes time to clear that potassium load, and there are detectable increases in the serum potassium, both intraoperatively and postoperatively, when using that potassium-containing cardioplegic solution. And so it follows naturally that the serum potassium will increase even more dramatically in patients who don't even have an ability to excrete the potassium load in their urine. So how can we help these patients? Well, of course, with careful planning, which is what nephrologists love to do. So there are several approaches that are implemented by different institutions to provide renal replacement therapy in the pre, intra, and post-operative periods. And great attention must be paid to the volume status in this pre-operative period and electrolyte arrangements by optimizing the dialysis plan before the patient even reaches the OR. And so for stable patients that are undergoing elective procedures, the general approach is to provide their outpatient modality, either conventional hemodialysis or peritoneal dialysis, within 24 hours of their operation. For patients who are critically ill or who have demonstrated an intolerance to intermittent modalities like acute coronary syndrome or hemodynamic instability during dialysis, we utilize a preoperative strategy that's continuous renal replacement therapy in an ICU setting. Shifting to the intraoperative management, there were early descriptions of management of ESRD patients undergoing surgical procedures requiring bypass that describe medical management only rather than any dialytic therapies. However, it's now recognized that intraoperative dialytic therapy is much preferred over medical management, given those unique intraoperative risks that we just discussed. It's not until the 1970s and 80s, though, where most case reports and case series start describing an intraoperative management plan that includes dialysis for such patients. And employing that intraoperative dialysis allows for both control of volume, acid base, and is very effective at clearing that exogenous potassium load. Some centers use the conventional hemodialysis, which we just described. Historically, it was the only option. Now others have actually used intraoperative CRT. Peritoneal dialysis is not typically utilized intraoperatively and not at our institution at all due to the possibility for pleuroperitoneal leaks, the poor splanchnic perfusion that's predicted during these challenging cases, increased transdiaphragmatic pressures from the PD fills, which can complicate ventilation in the OR, and then coordination, the difficulty of coordinating the peritoneal dialysis treatment team in the operating room. So let's take a quick look at how effective dialysis is intraoperatively. The table on the left details the intraoperative potassium balance and highlights the high capacity for potassium removal by dialysis. This study found the mean was about 160 milliequivalents during the case and exceeded the total potassium load that was delivered intraoperatively, allowing these patients to be in a negative potassium balance throughout the case. The right panel shows you what happened. All these patients received preoperative dialysis, intraoperative dialysis, and then postoperative hemodiafiltration, either intermittent or continuous, depending on how stable they were. And this shows the series compared to matched controls. So this is the dialysis group, and this is matched controls with normal renal function. And it's examining the change in potassium in the preoperative, intraoperative, and postoperative period. And while there was a predicted increase across these three time periods in both groups, there was no significant difference in the intraoperative potassium between the two groups. So intraoperative dialysis can certainly clear potassium and control the serum potassium compared to non-dialysis patients. While intraoperative conventional hemodialysis is very effective at clearing potassium rapidly, as is not surprising, there are also some untoward consequences of such rapid clearance, and many perioperative prophylactic antibiotics are readily cleared by conventional dialysis. Additionally, intermittent hemodialysis can also rapidly lower osmolality due to high clearance rates and lead to increased intracranial pressure depending on how well optimized the patient's dialysis plan was in the preoperative period or in patients with advanced chronic kidney disease who are not yet on preoperative dialysis. Those are very high-risk patients to provide dialysis to and for the first time during a case like this. Providing pre-existing dialytic modalities like dialysis or CRT intraoperatively was previously the standard of care for many centers, including ours, but presented logistical challenges. There are physical space constraints of the operating room, the complexity of the coordination of timing with dialysis technicians, setting up the dialysis machines, and then having dialysis nurses or ICU nurses, depending on whether it's dialysis or CRT, to provide these therapies while on cardiopulmonary bypass was quite challenging. So zero balance ultrafiltration is an alternative to the traditional intraoperative therapies and was first described actually in the pediatric literature in the 1990s. It's a form of convective ultrafiltration that utilizes pre-existing connections on the bypass circuit, and a hemoconcentrator is placed in parallel to the cardiopulmonary bypass circuit. This is a high flux polyethersulfone membrane hemoconcentrator that they typically use in cases when they want to hemoconcentrate blood at the end of the case. It's connected in parallel to the circuit with an inlet to the hemoconcentrator actually coming off of a shunt from the oxygenator and the outlet of the hemoconcentrator returning to the venous line from the patient, which ultimately returns to the venous reservoir. By applying a positive pressure in the blood and a negative pressure on the effluent line, we're able to establish a transmembrane pressure gradient, and plasma is then ultrafiltered out of the blood and across the membrane. And a commensurate volume of replacement fluid is added to the venous reservoir to prevent significant hemoconcentration and to allow for us to wash the blood with a potassium-free replacement fluid. This is conceptually the same as CVVH or CVVHF, which many centers use in their ICUs. This is a continuous modality that is preventative and should not be performed, should only be performed during the entire duration of the case. So it's not a reactive therapy. It's meant to help control the potassium before it ever rises. There is quite a significant rise that happens after the cardioplegia is given. And so it's important to have this upfront even before the cardioplegia is given. It's also important to note that while zero balance volume change is the a priori goal, using this pre-filter convective modality it is possible to have a negative fluid balance, as I alluded to earlier. And so intraoperatively, the CT surgery team, CT anesthesia, perfusion, and nephrology work together to communicate for what the volume balance should be by the end of the case. And the pressures can be adjusted so that a negative balance can be achieved by the end of the case if it's desired by the intraoperative team. So zero balance is the goal for our dialysis therapy or for our renal replacement therapy, but overall there can be a change in the patient's volume status depending on what else is happening in the operating room. Different solutions have been described for this purpose of replacement fluid, including crystalloids. This table is highlighting some of the differences in the composition with normal saline, lactated ringers, plasma light, normal. Some places have described using CRT dialysate solutions and then CRT replacement fluids. Because of the high volume that's required for this procedure, normal saline is associated with pretty dramatic hyperkalemic acidosis, and most centers use a more balanced physiologic solution. While some groups have described using that CRT dialysate solution in their protocols, these solutions are not FDA approved to enter the bloodstream. So using a CRT replacement fluid is the preferred strategy. And some of the key differences in the composition of these different solutions are highlighted in table 3. At our institution, we use these two replacement fluids, which have there's an option for 0K, 2K, and 4K. And then we have a protocol that I'll show you momentarily that uses 0K and 4K. And ZBuff using replacement fluid is quite effective at controlling intraoperative potassium for patients, for dialysis patients. This was a retrospective study of 245 dialysis patients who received pre-op dialysis using a low potassium dialysate in the 2 days leading up to the OR. Then they received intraoperative ZBuff. And then on post-op day 1, they either received hemodialysis or continuous veno-venous hemodiafiltration. There was very good control of potassium preoperatively. There was actually hypokalemia. And then by the end of the case, after ZBuff, the potassium of patients leaving the OR was 4.1. And there wasn't significant rebound by post-op day 1. The mean potassium was 4.7, which is pretty excellent control of potassium using a ZBuff strategy. There are no large studies randomizing ZBuff versus intraoperative dialysis and outcomes. But there is a study looking at whether there are any differences between the survivors and non-survivors. That same study, including 245 patients who received ZBuff intraoperatively. The overall mortality was 10%, which tracks pretty closely with the literature, which is cited as 12.5% for all procedures in dialysis patients. There were differences in univariate or contributions in the univariate analysis to mortality from diabetes, the ejection fraction, prior dialysis status, emergent operations, multiple procedures at the same time, and the cardiopulmonary bypass time. But in the multivariable model, only diabetes was the significant predictor or significantly associated with mortality. From my knowledge of the literature, it seems that centers either exclusively use Intra-op HD, which was the previous standard, or a version of ZBuff, which make the prospects of any randomized trial comparing HD to ZBuff very unlikely, and especially with more and more centers now moving towards intraoperative ZBuff. All right, shifting now from the intraoperative period to the post-operative period. That immediate post-operative period is a particularly vulnerable time for our patients, with many being very intolerant to any significant volume overload. And the choice and timing of modality will really be dictated by each individual patient's clinical condition. Performing CRT or convective ultrafiltration with ZBUF should not be thought of as replacing a conventional dialysis session due to that it's a continuous modality, not an intermittent modality. And for this reason, many centers aim to provide dialysis or some sort of RT within the first 24 hours post-op. Patients who have hemodynamic instability will obviously require CRT in this period. And while some centers have reported continuing peritoneal dialysis in the immediate post-op period, for the reasons previously stated, we do not do that at our center. And we wait at least 2 to 4 weeks before considering low volume PD. Once they've recovered from their critical illness, these patients are then transitioned back to intermittent hemodialysis. And this just highlights in red which modalities are not typically used in different periods. In the last few minutes, I'm going to share with you our experience in transitioning from a center who relied solely on Intra-op HD to now a robust ZBUF program. So we're located in New York City. We're a 750-bed tertiary care center. Of those beds, 56 are CCUs or CT ICU beds, and we have 4 dedicated cardiac surgical ORs. We're a pretty high volume bypass center with over 1,000 surgical procedures last year that required cardiopulmonary bypass. In 2018-19, we started reviewing our workflows in response to a need to free up some of the resources that were often on standby for these frequent and long duration surgical procedures that required one-to-one nursing and a lot of on-call staffing. And the goal is really to improve and simplify the management of hyperkalemia in our dialysis patients and to really improve the appropriate resource allocation for patients across the entire hospital. Candidacy for our protocol is dictated by how well dialyzed a patient is preoperatively. And these cases are reviewed individually with nephrology if the patient has not received pre-op RRT within the last 24 hours, or if the pre-op K is greater than 5.5, they land in this red box, which gets a review. The preoperative, there is also a preoperative multidisciplinary discussion that occurs in preparation for anticipated complex cases with prolonged cardiac ischemic times, deep hypothermia, and combined dual cardiac renal transplants. And in select cases in this yellow box, we do still keep dialysis on standby in the OR. And in general, however, most patients fall into this green box, which is the default modality of ZBUF. Intraoperatively, we utilize a weight-based protocol driven by the patient's most recent potassium concentration, and it's measured every 15 minutes with a point-of-care device. There's a sliding scale of potassium concentration of the replacement fluid and the volume that's ultrafiltered. And like we said before, the volume that's ultrafiltered should be the same volume of replacement fluid that's given. If the K is less than 4, we use a 4K solution to prevent any significant hypokalemia postoperatively. And we use a dose of 8 milliliters per kilogram every 15 minutes or 32 milliliters per kilogram per hour, which is slightly higher than the standard CRT dosing, which is typically 20 to 25 if you're not doing pre-filter. If you're doing pre-filter, it's typically a little bit higher. If the potassium is 4 to 6.5, we switch to a 0K solution at the same dose. And if the K is greater than 6.5, the dose delivered is increased by 50% up to 12 milliliters per kilogram every 15 minutes or 48 milliliters per kilogram per hour until the potassium drops back below 6.5. We're notified if the potassium is greater than 6.5 times 2 checks. Often it's quite high after the initial cardioplegia dose, but then quickly lowers. Or if there are any intraoperative issues or questions not otherwise specified on the protocol. This strategy uses pre-existing resources of the intraoperative team, since it's performed by the perfusion team, and simplifies the workflow in the OR. They're already present. There's no need to coordinate with the dialysis service. It's important to note, though, that this can only be provided when the patient's actually heparinized on bypass. And so if an intraoperative emergent indication for RT arises after separation from bypass, there has to be a multidisciplinary discussion very rapidly in order to deploy either CRT or dialysis to the operating room. Of those 1,000 cases, in the interest of time, I'll just let you browse this on your own, but the majority are isolated CABG, isolated valve, and aortic procedures. Of those 1,000 cases, so far we've had 87 over a 3-year period. This is just 1 year, so about 33 in this calendar year. I'm just showing you the breakdown. At 87 cases so far of ZBUF, the plurality were isolated CABG, isolated valve, CABG valve, and then these dual transplants. Despite these often long and complicated cases, we've had successful control of intraoperative potassium, with this graph just showing you the potassium measured at 5 different time points throughout the OR. Despite the max potassium being quite high during cardiopulmonary bypass, it's lowered quite effectively by the end of bypass and by the end of the OR, with pretty minimal changes, only a 0.3 increase for the OR and only a 0.5 increase for bypass. In the interest of time, I'm going to skip this, or I'm going to go over this slide very quickly just to say we do provide dialysis pretty rapidly after the OR with minimal net fluid balance accumulation, and the median peak potassium was 5.3. Since we've deployed this first pilot in late 2019, our ZBUF program has continued to grow despite COVID, and so far this year we performed 27 cases. We're on track to perform between 45 and 50. So what have we learned? CAD is common. Many of our patients require high-risk cardiac surgical procedures. There are unique challenges to normal homeostasis that occur in our patients, and that dictates careful preoperative coordination and planning. And utilizing this ZBUF convective ultrafiltration protocol using existing equipment and personnel has really simplified the intraoperative RT workflow here at Columbia. This effort is clearly multidisciplinary, and I'd like to thank our collaborators for all their help in the project. Happy to take any questions either by chat or by email. Thank you.